Good day, ladies and gentlemen, and welcome to the Home Care Sepsis Webinar 2. Currently at this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session, and instructions will follow at that time. Should anyone require assistance at any time during the conference, please press star and 0 on your touchtone telephone. At this time, I'd like to turn the call over to your host, to the Executive Vice President of the Home Care Association of New York State, Mr. Al Cadillo. Sir, you may begin.
Thank you very much, and good morning, and welcome all to this call. This is the second in a series of joint webinars on sepsis prevention, early recognition and treatment through home care. We are joined in this webinar, which is being hosted at IPRO. We're joined in this webinar, which is being co-conducted by the Home Care Association of New York State, the National Sepsis Alliance, with additional leader presentations by technology companies Home Care Home Base and NetSmart. And we thank all very much for their participation in the program. The focus of this webinar will be on integrating the Home Care Sepsis Tool and screening into agency electronic health records. It follows part 1 of the webinar series, which was conducted on September 30th, which launched as a first-of-its-kind initiative, not only in New York State, but nationally, an initiative that harnesses the statewide home care system in the effort for early sepsis recognition and intervention. The inaugural webinar provided critical background and facts on sepsis as a health emergency, and we heard from the CDC, the Governor's Office, the State Health Department, the National Sepsis Alliance, the Staunton Foundation, and other participants about the extent of that emergency, really highlighting the profound impact of sepsis on health, life, and the system at large, and that includes the catastrophic cost of the sepsis problem. It also focused on why sepsis is a community problem and why the involvement of home care and all providers is vital to prevention, life-saving, and care. The webinar presented, as I said, a first-of-its-kind home care sepsis screening tool, which was innovated by the Home Care Association of New York State in collaboration with key clinical and quality partners. And from that, we had national and state expert physicians and clinicians, IPRO, and others contributing extensively to the discussion and the formation of this screening tool. Our goal is that all providers, all home care providers, adopt and employ this life-saving screening protocol within your agencies. And our intent is that this webinar series will help provide the guidance and assistance for ultimately your adoption and use. We're also simultaneously seeking complementary federal, state, and philanthropic reinforcement in order to assist with the key health system partnerships and, again, to further assist agencies in the adoption of the tool. A recording of the first webinar has been posted at the IPRO site, and the slide deck includes the web link to that initial webinar. It's very important that, and really essential, that participants attend all 3 of these webinars in order to be prepared to utilize the tool. And I say 3 webinars because it's possible that as we go through the second one and then our third one, we'll find that there'll be merit in perhaps having another seminar. But it's very important to complete the entire series in order to really have the details and the handle on exactly how to go forward with it. Our next webinar, which will be on November 9th, will be devoted to a Train the Trainer initiative. So I would now like to review with you the agenda for the webinar. So we'll begin with an overview of the goals which I've just provided, but also we'll move towards some developments that we want to share with you since the September 30th webinar. There's a tremendous amount happening, a lot of momentum, and frankly it's all exciting given the nature of what has to come together to combat this very serious problem. Secondly, we'll have a second detailed walkthrough of the screen and protocol. That will be done by Amy Bowerman, who is the Director of Quality Improvement for the VNA of Utica and Oneida County and the Director of Patient Services for Senior Health Network. She's also been a member of our Quality Committee and the leader of our sepsis work group. Part of the importance of going through the tool again is because it will help set the table for the subsequent portion, which will focus on integrating the sepsis tool into your agency's electronic health records. And we're very privileged to have today two of the main electronic health record companies that service the HCA providers in the state, Home Care Home Base and NetSmart. So the further purpose of detailing the tool is also because in one walkthrough, you can't really come away with, I think, a sense of detail and a sense of comfort on how exactly the tool works, and also one that would address the questions that you have. So as part of that second presentation, we'll be queuing up the questions that were sent to us following the first webinar, and undoubtedly you'll have more questions after Amy's presentation today. But again, very important to try to nail down these details. Ultimately, this is an initiative that will also require training, further training at the provider and the clinician level, and that's another portion that we intend to queue up not only in the subsequent webinar, but for which we will be seeking support in the state budget making or in the philanthropic grant process to assist you with. In the fourth section of the webinar, we'll focus on providing you with some additional guidance for agency adoption of the tool, including experience and takeaways from the CMS iPro project being implemented in the state. That project is incorporated the use of the home care screening tool that we'll be reviewing with you today and training specifically on that tool. So Eve Bankart from iPro will be reviewing those experiences with you. And then finally, we'll look at next steps, and we'll talk about the overview for the next webinar section. Next slide, please. So I want to review a few developments since the initial webinar. So first, we received a very enthusiastic follow-up from the Visiting Nurse Association of America, which is the national association representing a substantial amount of home care in the country. And the VNAA reached out to us, enthusiastically looking to partner with us on ways to promote this initiative not only in New York State but across the nation. And so we're in contact on next steps. We provided them with a link to the first webinar, and we're in discussions on further steps we can take to promote the tool. Secondly, the Centers for Disease Control, which participated in our initial webinar, is in the process of also linking the September 30th webinar to their national website on sepsis. And we will be looking to further discuss ways in which our association, our partners, and the CDC can further collaborate on the goals of this initiative, which is early recognition, detection, and intervention on sepsis at the community level. We also had an invitation from the state Medicaid director for a meeting with him to discuss this initiative and what its promise might bring in terms of efficiency within the Medicaid program and advancement on the state's public health goals. The state Medicaid director is Jason Helgerson. We spoke about this initiative 2 days ago, and we're in the process of scheduling that meeting. We also have upcoming subsequent meetings that we're scheduling with the State Hospital Association. We've been talking about developing an initiative which would create a bundled payment model and perhaps clinical pathways for sepsis care when individuals move from hospital to community. The bundles, one idea for the bundles would be to target individuals, populations such as recurrent pneumonia, UTI, skin integrity patients, targeting those individuals for more intensive screening and an integrated relationship between the hospital and the home care agency upon the discharge of those patients. So that's something that, again, we've had several meetings with the Hospital Association about, and we are continuing those discussions. We also have upcoming meetings with the state administration and legislature to talk about the coming year's budget and legislative session, and sepsis is one of the key issue areas that we plan for those discussions. So those are some of the developments just since our September 30th webinar, and I hope you can see that there's a lot of momentum that exists around this issue, and I think a very important opportunity for driving the initiative forward and supporting the home care system's response and effort in this whole area. I now want to introduce Eve Banker, who is the Quality Improvement Specialist for IPRO and the Project Director for the IPRO CMS Sepsis Project, to talk to you about developments in that project since our webinar. Eve?
Thanks, Al. So as Al mentioned, IPRO has been, thankfully, a collaborative partner in this initiative, so we introduced the HCA Screen Tool at all of our training sessions. At the last webinar, I presented a brief overview of the community-based sepsis awareness initiative. And one of the core elements of this project is to provide pre-hospital providers, namely skilled nursing home, home health, and physician office staff educators, with sepsis training on recognizing the early signs and symptoms of sepsis. The model used for this is a train-the-trainer format. And the HCA Sepsis Screen Tool is introduced and walked through at all of the home health agency training sessions. The target regions for this initiative are the Syracuse and Albany hospital referral region. So since the introductory training on the tool began in April of this year, 6 regional train-the-trainer sessions have been held within the New York State target region: Albany, Glenfalls, Poughkeepsie, Utica, Syracuse, and the St. Lawrence region. 29 home health agencies have been trained by IPRO staff. 742 home health staff have been trained by IPRO-trained staff educators. Additionally, there has been some training outside of the New York State target region. On September 22nd, a sepsis training webinar was held for 20 infection preventionists from OPWED, the Office for People with Developmental Disabilities. OPWED covers all of New York State, so this is a great opportunity to spread this initiative. A second webinar is scheduled for the end of this month on 10/24, which is open statewide for all OPWED clinical staff. Also, the HCA Screen Tool was presented to the Department of Health Regional Office Home Care Program Managers back in June, and this was also another great opportunity to further disseminate not only the genesis of the Screen Tool, but also its utilization and the next steps that will be taken with it.
Thank you very much, Eve. Our next presenter on developments is Tom Heymann. Tom is the Executive Director of the National Sepsis Alliance. Tom has been was the initial catalyst several years ago in reaching out to HCA when he was reaching out to all sectors of the continuum on the problem of sepsis to really put the issue on the radar of the hospitals, the home care agencies, the nursing homes, physicians, and others, and to energize a thoughtful response, a proactive response within each sector to this problem, ultimately looking for a unified continuum of participating sectors in combating this problem area. Tom and the Alliance have been very close partners since we've been pursuing the development of the sepsis tool, both providing clinical expertise in the contents of the tool and supporting and reinforcing every step that we've taken. So Tom and the Alliance have been an incredibly invaluable partner in this whole process and are also in the process of reaching out to other states to also try to initiate similar initiatives, again, at the home care and hospital level across the country. So with that, Tom?
Thanks, Alan, and thank you all for being on today. I appreciate the opportunity to speak to you just briefly here. Sepsis Alliance was founded in 2007. Neither Carl Flatley, the father, or Carl Flatley, the surgeon, had ever heard of sepsis when his daughter Erin died of sepsis after what should have been a routine surgery. Dr. Flatley looked for an organization involved in sepsis to join and help other families avoid what his family had just gone through. So clearly, we have had and still have to some significant degree a public and a healthcare provider awareness challenge. Since 2007, the founding date of Sepsis Alliance, we've grown into the nation's largest sepsis advocacy organization with the needs and interests of the patients, public, healthcare providers, and also a large number of sepsis survivors. Our website, sepsis.org, provides information, resources, and supports more than 1 million visitors each year. And when we started back in 2007, we understood there was an awareness challenge that was, going to prevent any effective action in the fight against sepsis. And in fact, fewer than 1 in 5 American adults had ever heard the word sepsis before. And we put that as our central focus. We realized that if we couldn't increase awareness of something, it was going to be hard to get people interested in fighting against it. We now do an annual Sepsis Alliance survey with Nielsen and Harrison Interactive, and I'm happy to report we've made some progress. We've gone from 19% awareness in the U.S. to 55%, which means nearly 100 million people now are aware of sepsis who were not prior. We still clearly have a lot of work to do. Just 28% of the population can correctly identify the symptoms of sepsis. So we need to get to a position like with heart attack and stroke where we really, public is tuned up, healthcare providers are tuned up to be looking for sepsis, and we save a tremendous number of lives. Critical to raising awareness has been the launch of Sepsis Awareness Month back in 2011. And we did this to give everyone a focus for accelerating efforts around sepsis awareness and education. And a year later, we launched Sepsis Heroes as a way to recognize outstanding work of sepsis advocates, professionals, and organizations who are working to help save lives. We're active now in more than a dozen states with community volunteers driving sepsis awareness events, 5K walk runs, strikeout sepsis volleyball tournaments, strikeout sepsis baseball and bowling events. We even have someone doing the Scare Away Sepsis Halloween event. And these are all aimed at raising awareness in the community. The media has also turned their attention to sepsis in a more meaningful way, and certainly the recent deaths of Muhammad Ali and Patty Duke being correctly attributed to sepsis were certainly helpful in raising the level of awareness. I've had recent articles in the Washington Post, Philadelphia Inquirer, and New York Times, Huffington Post, and others about sepsis, and we recently joined with the CDC in a joint press conference announcing the results of our new survey, and the CDC coming around to acknowledge that sepsis is a medical emergency, something we've been asking them to do for many years now. We've also recognized that children are the other most vulnerable population, and this year we launched a campaign called Erin's Campaign for Kids, which is developing programs with Children's Hospital Association and others to educate families and caregivers about sepsis in the young population. We also have a public service announcement running nationally on Hulu and other platforms, and that PSA just won a Marcom Marketing Award. We're very proud of that, and millions of people have seen this public service announcement. So we know a lot about sepsis, right? We know it kills 258,000 people a year. We know it's the #1 cost of hospitalization in the country. Also very expensive for aftercare, over 1 million survivors each year. And we also know that we can save as many as 80% of the lives that are being lost and a lot of the costs that are being attributed to sepsis. We also know that adults age 65 are 13 times more likely to be hospitalized with sepsis than adults younger than 65. We also know that sepsis is a leading cause of readmission to a hospital for adults 45 and older. And we know that nursing home residents are 7 times more likely to have sepsis. And we also know that the vast majority of cases of sepsis originate in the community prior to hospitalization. And we know that mortality from sepsis increases 8% every hour that treatment is delayed. So as many as 80% of deaths can be prevented with rapid diagnosis and treatment. So we have the opportunity now to elevate the fight to the size of the challenge. And Sepsis Alliance and the fight against sepsis runs on partnerships. And we are so appreciative of our partners, IPRO and Home Healthcare Association of New York, in the effort to help save lives and protect our most vulnerable populations. And we appreciate your involvement in this effort. Thanks very much.
Thanks very much, Tom. And I think for all on the phone, I think Tom certainly captures the extent of the sepsis problem, some of the many initiatives underway to try to address it, but certainly a great degree of challenge and work that still lies ahead in confronting this really top killer and top health coster in our system. So here now to review with you our initiative, our attempt at contributing to solutions for this very serious public health problem is Amy Bowerman. Amy will be presenting the next section of this webinar, which will present once again in detail the HCA Sepsis Screening Tool and Protocol. The tool, as I mentioned earlier, the tool was originally presented in our September 30th webinar. It was created by the HCA Quality Committee and a subwork group on sepsis from that committee, and it followed an extensive 2-year effort of research, development, beta testing, piloting, partnering, and vetting with clinical experts in the field. Following Amy's session, there will be a discussion opportunity for questions and answers where Amy will review questions that were raised following the first seminar, and then there'll be an opportunity for you to, at that point, to raise specific questions that you have about any aspect of the tool, either detailed or generally, in terms of incorporating that within your agency. Next slide, please. So an important notice about the webinar screens and the use of the tool. It's important to note that all the text, methodologies, and processes, courseware, images, and other materials in the webinar and the tool are the proprietary information of the Home Care Association and are intended for use solely in connection with this webinar. We ask that you please not distribute the information or copy the information in any way. Ultimately, when the webinar series is completed and the tool is circulated, it will then be circulated with the intent clearly for distribution and use when there is a comfort level that the tool has been presented with all the details that are necessary for it to be properly and effectively implemented within your agencies. So with that, I would like to now introduce Amy Bowerman, who will present the sepsis tool and protocol. Amy?
Good morning. Next slide. In 2013, the New York State Department of Health mandated acute care facilities to implement policies and protocols to easily identify and rapidly treat patients that were identified to be at risk for sepsis or were actively septic. The goal was to improve patient outcomes and decrease mortality. Early recognition and treatment is what saves lives. The Adult Sepsis Screening Tool was developed to assist and streamline a clinician's assessment to recognize the clinical signs and symptoms of sepsis in a post-acute setting such as home health care, based on some of the same guidelines issued from the Department of Health for acute care facilities. The Sepsis Screen Tool crosswalks the same information that is obtained during a triage in an emergency department. So the information is recognized when reported to the emergency department to expedite a patient's care, providing rapid treatment, which is a key factor in decreasing mortality and improving a patient's outcome. Next slide. The screen tool is a sequence of 3 questions. The questions are answered based on a clinician's assessment. The screen tool does not require a specialized assessment. The screen tool can easily be answered by a clinician doing a routine head-to-toe assessment. The answers are based on clinical findings. Once all the questions have been answered, the screen tool provides the clinician with the information to determine if the patient meets sepsis criteria or if the patient is at risk for sepsis. Next slide. Question 1. Does the patient's history, physical exam, or other findings suggest an infection or a potential source site of infection? There are some suggestions provided on the screen tool, but this is not all-inclusive to the possibilities. Some of the obvious source sites for infection are Foley catheters, immunocompromised patients, and open wounds. However, what about the patient who has had a pacemaker for years with no complications? Is the pacemaker a potential source site of infection? Yes, the pacemaker is a potential source site of infection. So question 1 would be answered yes for that patient. The purpose of question 1 is to assist clinicians with critically thinking for all identifying possibilities of potential source sites of infection and not just the infections that are active. Question 2. Are any 2 systemic criteria present? Simply, does the patient have a fever or are they hypothermic? Is the patient tachycardic? Or is the patient tachypneic or having rapid breathing? The answers are based on the objective data obtained from the patient, remembering that the patient needs to have 2 of the systemic criteria present. Question 3. Is there at least one new onset of sepsis-related organ dysfunction criteria? A key point to this question is new onset. So patients who have a baseline of organ dysfunction or respiratory, who has an oxygen level baseline of 88%, and their SBO2 is currently 88%, would not have a new onset for that parameter. However, if you have a patient who is alert and oriented routinely at the last 5 screenings, and then the 6th screening, the patient is now disoriented and confused, this would be a new onset for neuro, altered mental status. The other organ that we look at is kidney dysfunction for a decrease in urinary output, cardiovascular for hypotension, and of course the patient's skin coloring, whether or not it has become pale or discolored. And new onset of pain. This question number 3 will provide clinician recognition if a patient meets criteria for organ involvement and requires immediate treatment. Next slide. After a clinician has completed the 3 questions, which takes less than about 5 minutes to complete, the clinician then continues to the follow-up area on the screen tool. The follow-up area provides direction for the clinician to determine what type of follow-up is required based on the answers to the screen tool questions. Example. The patient has a source site of infection but does not have any systemic criteria or organ criteria. That patient would receive education on the signs and symptoms of sepsis and what a patient should do if they had signs and symptoms of sepsis. Another example would be a patient who has a yes to question number 1. They have a sore site of infection. The patient has a temperature, and the patient has a rapid heart rate. So they have 2 systemic criteria, and also has a new onset of pain, which is the new onset of an organ dysfunction. This patient has met the criteria for severe sepsis. This patient would need immediate follow-up and intervention. Once that follow-up and intervention would require, let's go to the next slide. These are your interventions. Those interventions would require a patient to be, you would need to notify the MD, and the patient would need to be transported to the emergency department. One of the key purposes of this screen tool is that it does crosswalk the information that the emergency department is obtaining on triage. Once the patient has been transferred to the emergency department, it is important for the clinician to provide coordination of care for the patient by reporting the findings to the emergency department that the patient is being received at, stating the patient meets criteria for sepsis, and providing the details as to why. This will expedite the patient's treatment. Each follow-up item provides direction for the clinician, and the intervention area on the screen tool provides suggestions for appropriate interventions for the patient. The interventions are not all-inclusive of what may be done. A doctor may order an intervention that is not on the screen tool, and in that case, the clinician would just need to document the intervention that was ordered in the appropriate area in the patient's record. The screen tool is not intended to be used as standing orders for a provider. It is an SBAR tool and may be sent to a provider for communication as appropriate. The sepsis screen tool flow chart, next slide, or algorithm, walks the clinician through the process of the tool. It is designed to be a quick reference guide for the clinician. Next slide. And here the algorithm has been broken down into the sections of each part of the screen tool. Next slide. And there's your follow-up and your intervention. Next slide. Early signs and symptoms of sepsis zone sheet is designed to educate patients on the signs and symptoms of sepsis. Most people, if asked what the signs and symptoms of a heart attack are, they would be able to state a few key signs and symptoms and what they would need to do if they felt that they were having a heart attack. With sepsis, many people have never heard of sepsis, nor can they state signs and symptoms of sepsis or what a person should do in the event that they develop those signs and symptoms that indicate sepsis. This sepsis zone tool is on a red and green, provides a person for information of what the signs and symptoms are and what to do if they develop these symptoms that are easily understood. It is intended that the sepsis zone education sheet be left in a patient's home as a reference for the patient and for a clinician to continue to reinforce the initial education. Next slide. Some of the key points about the sepsis screening tool. The screen tool is meant and designed to be completed at every visit. This to be including starts of care, resumptions of care as well. Every visit, every time you see the patient, you would need to screen the patient. The interventions are recommended interventions and not a substitute for treatment, consultation, or direction from the physician or authorizing practitioner. If the providers choose to order test interventions not listed on the tool, or that they are listed on the tool, they do need to document, and you may need to document an order from the provider. Patient and public education component is significant. It is important to educate the patient in regards to sepsis. Next slide. Some of the sections that were received from the previous webinar one were LPN utilization of the screen tool. Yes, an LPN scope of practice does not allow an assessment of a patient. However, an LPN may collect the data and have it interpreted by the RN, oversighting RN. An LPN in the home may complete the tool by gathering the data, and in the event that any of the information that has been obtained falls outside the parameters, then the LPN would be contacting their oversighting RN. The RN would assess the data obtained, determine interventions, notify the MD, and take orders the MD provided and educate the patient. It is important to note that the RN must take the MD orders because the orders would be based on the RN assessment. Next slide. Pulse oximetry readings. There has been question in regards to pulse ox not being considered a standard vital sign in home care and can be only done by MD orders with patient-specific parameters. The screen tool does suggest utilizing the use of pulse oximetry. The answer to that question is a pulse oximetry is a non-invasive measurement that it would be no different than a temperature measurement. We have confirmed with the Department of Health surveillance that you need parameters for MD notification, just like a temperature, and may use PRN orders for the oximetry utilization, but you must have parameters when to use it and when to report the findings to the provider. Next slide. Questions concerning the temperature parameters in various different articles and tools, etc. We have come up with the standard for 100.9, and this is consistent with Surviving Sepsis Campaign and Systemic Inflammatory Response Syndrome criteria. So that is why we have based the screen tool off of that evidence base. Should we be doing the sepsis screen tool on antepartum and postpartum patients? The answer to that is yes. Early recognition of sepsis is what saves lives. Completing the screen tool for these patients could potentially provide early recognition and treatment of infection. Next slide. And here we would like to open up if anyone has any other questions in regards to the sepsis adult screen tool.
Operator, are there other questions in your queue?
And can you unmute there?
Ladies and gentlemen on the phone, if you have a question at this time, please press star and 1. If your question has been answered and you wish to remove yourself from the queue, please press the pound key. If you have a question at this time, please press star and 1.
There will be other opportunities to revisit this when we go through general questions in the webinar. So if you don't have a question on this now, don't worry, we can come back to it.
I do show we have a question from Mary Hornick of Visiting Nurse Service. Your question, please.
I'm just curious, and I guess I need clarification on the tool at this point can't be copied or used. So what do you recommend that we use for screen?
Well, this is Alan. I can answer that. What we prefer is that at this time that the tool not be copied and used. I mean, it has been used. It's being used in the context of the IPRO study, and agencies that have been trained in the use of the tool have it and are using it in conjunction with that pilot and with that study. But outside of that, we ask that agencies hold off doing that until we've at least completed this webinar series and determine if anything else is really important before kind of green lighting this. So that's what we ask at this time. And when we release the tool, we'll release a proper version of it, because what you're seeing is really a screenshot of the tool as part of the webinar. One of the things that we want to avoid, and I just want to elaborate a little bit, is that Amy went through all of the thinking that's really necessary and critical to utilize this properly. And what we don't want is for agencies to have basically to have a copy of the assessment form, make it available to their staff, and then the folks basically use the assessment on start of care or resumption of care or on reassessment, or aren't really using it correctly. It really gives a false sense that the tool is being used in a way that's achieving the intended goal. So we really want to be very cautious about that aspect of it.
So then is the plan to, once the study is completed and the tool has been finalized, to give us like further instruction and an okay?
Yeah. Absolutely, that's what we'll do. It's upon completion of the final webinar, which might be the next one, or we might need one more to fully cover the area. Upon completion of that, then we will make an announcement about the accessibility of the tool and the procedures for our circulation of the tool to any. We want to make this available to any and all home care providers. Yes.
Okay, that's great. That's really good. Thank you.
Thanks so much.
Thank you. I should have some questions in the queue at this time.
Thank you very, very much, Amy. And I certainly would like to say, again, I think for the benefit of the entire group that's participating on the webinar, that the amount of effort that's gone into the development of this and the leadership that Amy has shown has really been extraordinary. And on behalf of the association, Amy, thank you so much for all of your time and effort and leadership in this whole process. So I would now... Go ahead, Amy.
But it has been my pleasure. Sepsis is definitely one of my passions.
Thank you. So we're now very privileged to have with us today for this next portion of the presentation, which is really going to focus on the integration of the tool within agency electronic health records. We have two of very significant EHR companies who are ordinarily engaged with the HCA membership to talk a bit about this topic area. This may be one of the discussions that we will need to follow up further on in the next session, but we'll kind of wait and see how this flows today. But to start, we're very privileged to have with us Chris O'Donnell, who's the sales account executive for Home Care Home Base, and Jonathan Noxinger, from Knowledge Link. He's the product specialist in that, also from Home Care Home Base. Chris?
Thank you, Al, and thank you everyone from HCA New York for allowing us to participate in this exciting initiative. I wanted to start and talk a little bit about the design of Home Care Home Base and how we might accomplish the integration of this tool into our customer databases in New York. So all of our customers at Home Care Home Base, they really operate off of one version of the Home Care Home Base system. Now, within that version, there's really 4 core building blocks of the system, and one of them being forms and form customization. So within the product, as your clinicians are working through their different body systems and their head-to-toe assessments, we really have the ability to customize any assessment item, any question, and any assessment item response that your clinicians may select. Now, of course, all of our customers start with a best practice database for either home health or hospice or both, and it's through the implementation process that they would go through and customize these forms. We actually have a customer in New York right now that's going through an implementation, and we're in discussions with our implementation team right now as to how we might integrate this new sepsis tool into our assessment. Now, once we have those data points and those finite data items within the system, we have another tool which is called Knowledge Link, which gives us the ability to extract that data and to pull that data to any dashboard or any report that you can imagine. In the core system of Home Care Home Base, there's over 700 reports, but with Knowledge Link, we really say if you can dream it up, you can build it within Knowledge Link. So I want to turn it over to our Knowledge Link product specialist, Jonathan, and he's going to talk a little bit about that application and how we might use that in reporting on this sepsis tool. Jonathan, whenever you're ready, go ahead and take us off mute and take it away.
Hey, Chris, can you hear me?
I can.
Perfect. Well, thank you, everybody, for letting us on here to discuss it. It's exciting for us as a part of the custom report building team to find out about these initiatives, especially when there is already logic in place, just like we've been talking about this entire call, for us to really take and run with within our product. And just like Chris said, the things that we've been discussing is really building in the SBAR form and really applying the logic to the questions, kind of taking out that manual tracking and saying, okay, if this happens, then this is the protocol that you need to follow. Here is the score. Patient meets criteria for severe sepsis. What are our follow-up questions? What are the interventions? Where should they or when should they take place? And really putting that in the hands of the clinicians to not just make it easier, but to really enhance their ability. Taking it from there, what we can then do on our side is build specific dashboards for giving clarification as to the trends that we're seeing, which patients are being affected, and what ultimately can we provide to the decision makers in the back office by dashboards, which is going to be multiple reports in one easy-to-view screen, and then ultimately digging down and building out data sources. So based on questions from the head to toe, what kind of interventions are typically appropriate for this patient depending on where their sepsis score is, what interventions do we need, what type of follow-up do we need. So it's really exciting for us to really dig into the details, like I said, and develop specific data sources, if it's a cube source, if it's a relational data source, digging into the quality measures and making it easy to extract that from the field and, like I said, put it into the hands of everyone who's monitoring those patients and those specific diagnoses. So that's just a little bit about it. Again, it's very exciting for us, and I appreciate you guys letting us on here, and I will pass it back to Chris.
Thanks, Jonathan. That provided a really good overview. Al, that's all we have for today. I look forward to digging more into the details and potentially setting this up with some of our customers in New York, and we look forward to that follow-up session.
Thanks very much, Chris and Jason. I want to make sure everybody on the call is aware that following the next presentation, which would be by NetSmart, we're going to open it up again for questions. So if you have your systems people on the phone or on the webinar with you, or anyone that has a systems question that you might want to pose to any of the HR representatives on the phone, please do that. Even if the answers aren't there today, it would certainly create an advance to look into the issue area for the next time that we're together and we review this in greater detail. So again, thanks very much, Chris and Jason. We're now going to introduce. Now I want to introduce Jason Banks, who's the Area Vice President of Home Care from NetSmart, Kevin Sherman, who's the Client Development Executive for NetSmart, and Marie Finnegan, the Director of Home Care Solutions Management for NetSmart, to present their thoughts and perspectives on this issue. Jason?
Sure. Thank you, Alan. Thank you for the HCA of New York, and thank you everybody for joining today. So just wanted to give kind of an overview. We have a number of clients in New York, home health and hospice clients that we work with. A number of them are using our system to start gathering and tracking information on the sepsis tool. And so if you flip to the next slide, we have kind of screenshots. Actually, it's the one after this. We have probably 4 to 5 clients who are starting to build in assessment customization to be able to track and monitor both on a assessment level and on a care plan intervention and goal level, being able to track, document, and report on sepsis screening measures as based off of the sepsis tool. We have as I said before, we have a number of clients in New York State today that are using the tool, and we are looking to further enhance the way that our clients can customize their assessments to track, screen, and then report on those patients that are at risk for sepsis. And our tools are flexible enough to accommodate for the assessment build of this, as well as the tracking and reporting on it. And we're happy to be working with HCA of New York on the sepsis screening process, as well as our mutual clients within the state of New York.
Thank you, Jason. Did Kevin or Marie want to add to your comments? Do you want to add further comment, or should we go to questions?
I was just going to add a little bit to what Jason says, and he did a great job kind of sharing how the information is gathered within the assessment and the care plan file. But I think it's really that once you get that data into the system, kind of the power of the analytics and the dashboards behind it, how you can track and report the number of sepsis cases and kind of drill into the details. But Al, that's all I had, and certainly appreciate everybody from the HCA and IPO for allowing us to present on here.
Thanks very much, Kevin. Could we now open it up for questions? Any questions at all with respect to your thoughts as you listen to the two presentations and as you contemplate the information in the tool and its applicability within your records? I mean, I can't say that I spoke with some individual agencies who are part of the pilot study now. They're anticipating being able to integrate, but they're also able to pretty efficiently use the tool basically in paper form at this point until that time. And I think that goes to a point that Amy made early on when she said the first several questions take all of about 5 minutes to complete. So that was part of what we aimed for as we were formulating and then beta testing the tool, how user-friendly the tool was even in paper format. But obviously, in an age of integrating information, and then particularly as information will be important to have in the queue between home care and hospitals, it's certainly very, very important to think about the integration of this into the records. So questions at this point from our audience?
Thank you. Ladies and gentlemen on the phone, if you have a question at any time, please press star and 1. If you have a question at this time, please press star and 1. Actually, we have a question from Susan McCarthy. Your question, ma'am?
Yeah, is the NetSmart going to incorporate the SBAR tool into the assessment at all? Or we use NetSmart, and we've incorporated it into our care plan, but we were just wondering, I think easier for the clinicians would be if it was incorporated into the assessment, like the grade tool or like the full assessment or that kind of thing.
Hi, thank you. This is Marie. The agencies can take those assessments, customize them, and add that tool in. And as you noted, you can also use the care plan to enter in this tool. But we're certainly happy to investigate and look at building this into the assessment sometime in the future.
Right. Okay, thank you. We would look forward to having it into the assessment because it would be much easier for the nurses to work with.
Thank you very much.
Thanks.
Thank you. Ladies and gentlemen, if you have any further questions at this time, please press star and 1. If you have a question at this time, please press star 1. I show no further questions in the queue at this time. You may continue.
Thank you. Can I ask, Chris and Kevin, will you be staying on the call for a bit longer in case questions reemerge as we go through?
Yes, I can.
Very, very good. Thank you. Yeah, thanks very much. So we now go to the next section, which focuses on guidance for agency adoption of the tool. Amy, are you on the call? I just want to ask first, I could go through these slides, or I wonder if you might want to go through this slide 37, or we do it together?
We can certainly do it together.
Okay, so we frame out what we believe are some critical points for an agency's adoption of this tool. So the first is buy-in from the agency leadership. So with the tool really being recognized as an important additional ingredient to the agency's clinical practices with respect to all of its patients. And we'll go through one bullet at a time. Amy, do you want to add anything further to that?
I do think that is very, very important. Having that support from leadership for the implementation and the continued utilization of this sepsis screen tool really impacts on the clinicians and their utilization of it. I can speak from my own experience, having all of our leadership be very supportive of this project and process. We are currently utilizing it in a paper format, and the clinicians have really got hold of it and ran with it, so to speak. So I think that's a very important factor.
So the next item relates to staff training, effective discernment of the criteria, and effective application of the screen. I just want to speak to this from several levels. First of all, with respect to the training, and I would also invite Eve to comment on this as well, since they've been doing an extensive amount of training. We really believe very strongly that the training is a very critical element of this process. So it's a matter of carefully applying the tool and again doing it correctly, understanding the fields and following through on the intervention side correctly. I had the opportunity to attend a sepsis event that the National Sepsis Alliance and Tom Heymann invited me to participate in, where there were individuals. Tom mentioned the sepsis heroes. There was a health system, the Kennedy Health System, that I believe is in New Jersey, that was recognized for its work nationally in the progression of reduction in sepsis morbidity and mortality. When I spoke to the CEO of that system about our initiative, which he was very interested in and kind of looking to see how we might collaborate, he said to me, there's three things that you need to remember: training, training, training. And then he repeated it: education, education, education. That is the formula that made it work in the hospital. That's the formula I recommend to you. And that has been a focal point since we first started this initiative, before the tool was really developed. When we were just contemplating our action plan for going forward, training was just a huge part of it, and that is something too that we are going to be seeking support for in the system. But nevertheless, that being very, very critical. Amy, let me turn it over to you to comment, and then certainly invite comments from Eve.
I concur with you, Al. Training is a huge, huge piece for the clinicians. Even after they have utilized the screen tool, there's generally questions that arise out in the field, and that there's more training and education that continues going forward as they continue to utilize it. So I think that continuous ongoing education, even if it's just a review at a staff meeting or something along those lines, just to have that continuous education and follow-up for it.
So I just wanted to echo what Alice emphasizes, that probably the biggest takeaway that we've experienced in our training sessions is, from the feedback from the participants, is that senior leadership support is really vital for the success of this initiative. As I'm sure all of you are acutely aware, that you really get the buy-in of leadership, you can do just about anything in your organization. So, I think these webinars are really providing a great foundation for you to understand all the details and all the thought and the critical thinking that went into developing this tool. And as you use it, you'll probably perhaps come up with your own questions. But I do believe that through all of the pilots that we've conducted and all the revisions that have been made to the tool, that I think for the most part, all of the questions have pretty much been answered in the final product.
Thank you, Eve and Amy. So the next is what we really talked about, really was the core focus really of the webinar, which was the incorporation of the tool in your EHRs. And again, I think that's all emphasized by the comments that have been made around us today by our leader presenters in that area, home-based, home care, and NetSmart. The next portion really is on evaluation, tracking of outcomes, and feedback for potential improvement. So we know that in comparison to what we have today in home care, which is really not a tool of this sort and not a focal point for sepsis recognition, we know that the incorporation and application of the tool is itself a best practice that will lift all agencies in regard to sepsis early recognition and intervention. But that said, it's an evolving area. We know that we may not have the perfect tool, or as other findings within the field advance, there may be recommendations for changes. At the same time, it'll be very important that we be looking to try to track the findings with respect to this, because to the extent that home care agencies are identifying active cases, whether it's sepsis or whether the tool leads you to identify and be more apt to identify other infections, which through early response, you're able to have a benefit to the patient and also a cost reduction. It will be very important for us to document this as it contributes to the broader goal of public health, but also the positioning of home care with respect to its contribution in this problem area. So if I just take an example of Becky Gray, whom you know is the director of Home and Community-Based Services for the Department of Health, she was a presenter in our first webinar. And Eve and Sarah Butterfield from IPRO had provided Becky with some data on the incidence of hospitalization from sepsis that occur right now within home care. The interventions that home care might be able to yield through this tool, to the extent that those outcomes are improved and again costs are reduced, could provide a very important basis for the state to be attracted to further invest in home care from a training perspective or from a support perspective in terms of investment in agency, EHR, and technology that will drive this forward and further drive forward some of these important milestones on improved patient health and prevention as well as cost savings. So evaluating and tracking the outcomes for purposes of our increased work toward refinements in the tool, should they become necessary, or refinements in the science as that comes along, and three, certainly verification of the work that you're doing are all important. And the last point that I'll make on that I think is very critical is, every agency right now is functioning in a value-based, performance-based environment. You have hospitals, physician practices, health plans that are all looking at potential partners for what contribution can they make to improve the broader system and improve the care of patients and reduce costs. Certainly to the extent that you are documenting that you have this initiative in place and that it carries aim toward the number one cause of Medicare readmissions in the state, and it is number two in terms of the state Medicaid hospital impact. So you are taking a step forward to resource yourself in an area that really is a priority public health and expenditure area. So the extent to which you can go forward into that market, into those partner discussions and say, we have implemented this best practice initiative in sepsis, here's what we're doing as a result, it certainly is a very, very important piece of information to bring into those discussions. Amy or Eve, I invite any other comment on that one.
The only comment that I just wanted to add to that, and it's really, I think, going to catapult this whole initiative, is the fact that greater than 80% of all sepsis cases originate outside of the hospital. So bringing this first-of-kind tool that's going to identify sepsis early on in the home care setting is really going to drive morbidity and mortality rates related to sepsis down.
I would point out that hospitals that have implemented this, so two that come immediately to mind. So one is the Kennedy Health System that I mentioned. The other is the Northwell Health System on Long Island. their sepsis mortality rates, went down by double digits as a result of their implementation of best practices. Not just the screening requirements that the state required under the what are often referred to as the Rory regulations, or the Rory Stoughton and the Stoughton Foundation that worked very diligently with the state on that, but also because of the training and education aspects that were implemented throughout those systems. So again, two very important ingredients coming together to achieve that improved outcome. And as Eve highlighted again, the high volume of these cases in community, and as Tom Heymann mentioned earlier in his remarks, the population that really embodies among the greatest risks for sepsis is the very population that is in home care: the elderly, the immunocompromised, medically fragile children, individuals who are chair-backed or bedbound or who are on catheters, et cetera. We know that a significant portion of our population are the at-risk population. So home care is really well situated. And then the other piece is that home care, because it's in the communities, it's in the homes, it's in the neighborhoods, is a well-positioned ambassador for public education on this. First and foremost, with your own patients and families, as both Sarah and Eve have reviewed the Zone tool, but beyond that, in terms of the kind of community outreach that you typically do in areas of importance for the community health. So this really adds another important piece, and again, you are well positioned because of the way in which you are structured as agencies, the way in which you interact with the cultural diversity of your neighborhoods and communities. You are so well positioned to be an effective responder. Amy, any other comments on that? Bullet?
No, I think you summed it up well.
I think I more than I think I went around and through it and back, but which is such an important one. The next one really involves the effective work with partners. I'll just speak briefly to this, but certainly I'll look to comments from Amy and Eve. So the effective work with partners, physicians, hospitals, EMS, very, very important in making this work, because part of the equation is obviously on your screening and your own detection, but then what happens when there's a finding that then needs to be reported, and the extent to which, first of all, the tool, as Amy described, is structured with a natural crosswalk in language and criteria to connect to these systems. But then secondly, the familiarity of your own agency staff in communicating with that language, and communicating with the criteria that folks are going to be looking for is so critical. Yesterday, our association sponsored a special meeting of our policy council which focused on physician-home care partner relationships. One of the attendees at that meeting was the vice president for clinical affairs at a major patient-centered medical home in the state, and also co-sponsor of a large PPS. When they learned that we had the sepsis initiative in play, the director's first response was, this is a major problem that we see in our practice, and we want to work with you to try to make sure that we integrate that as well into our own practice. So the development of these partnerships is so key. Amy and Eve?
I agree with you, Al. I would encourage everyone, once you have adopted and started utilizing the screen tool, that you reach out to your partners, the providers, the hospitals, and EMS that you work with, and let them know that you are utilizing this screen tool. So when the clinicians are calling and sending the patients in, and this is the report that is being given to the receiving providers, that they have a full understanding that we are well-versed with sepsis, we are well-versed with how to screen it, and we are calling you with criteria that meets sepsis criteria, and that this patient's care needs to be expedited quickly.
And this will really be part of our follow-up effort as well in our association in this sepsis work group among our partners, This area of fostering this collaborative relationship and making it work is something that we will also be following up at our level. As I mentioned earlier, we've been having discussions with the physician community, with the state hospital community, and with others to try to get everyone on board for this mutual working relationship. We've actually had some discussions with the State Hospital Association, and the United Hospital Fund on how we might be able to craft a grant that would support some of this collaborative development. So very key. And the last item on the list is really something that is very important that all of you can do as well, which is really to be vocal in the need for public support for your efforts to be able to adopt this into your system. So certainly training, EHR adaptation, those kinds of things, outreach to partners. You're right now inundated with many, many pressures and things that you have to do, many mandates that are not funded, and time that's very precious that you're trying to prioritize and allocate. Certainly, you could use support as you marshal through with this, and again, something that the CDC has recognized as a national health emergency. Michael Dowling, who is the CEO of the Northwell system, who was the keynote speaker at a National Sepsis Forum earlier in September, one of the comments he made was, it's great when the system follows a requirement and a mandate and does a good job at it. But it's another complete story when a sector or a group of health professionals knows what is the right thing to do and steps up to do it without having to be asked. And that's really what we're trying to do as an association and what we're calling all of you to try to do. And I think to the extent that you all step up and step into this very important public health response merits the support of our public officials to support you. So when you meet with your public officials, when you meet with and have discussions with folks that are in a position to be helpful, maybe it's a foundation, maybe it's a local philanthropy group, I think it's important to try to draw attention to what you're doing with an initiative like this and try to draw support, even if it's not individually directed. It certainly primes those elected officials when we go to them in the budget and say, this is a worthwhile cause. We're still in that mode where it's a little bit of deer in headlights, where we go, we talk about the issue, and it's very difficult for officials to make the connection. But if we continue to work on it at all levels, I think we'll get there. Let's go to the next slide. And Eve, I think you have some experience to share further with the agencies from the IPRO project.
Well, I think we've pretty much covered the senior leadership support aspect and how important that is. But I'd like to kind of just echo Al's last comment about the proactive nature of this initiative. We have found from experience conducting these training sessions that the feedback, which has been unanimously positive, has mostly been that staff is surprised at the data and statistics related to sepsis. As Tom Heymann mentioned, Americans are pretty aware of stats related to heart attacks and stroke, but not so much, not yet anyways, that familiar with those related to sepsis. So I think the reaction from the professional staff when we introduce some of these stats is really very telling. And it's also an indication that this proactive approach that we're having with the tool is going to be well accepted. One of the quotes that I got as feedback is that the training sessions inspired awesome discussions. And that really, to me, is very inspiring in that they're not just, looking at all the aspects of the tool, but they're also having discussions about how can they implement it, how can they utilize it in their agency. And one of the things that we decided to do back in August was to send out a survey to see how these agencies, number one, if they were utilizing the tool yet, and what their experiences were with using it. And so the biggest response that we got back, overwhelming response, was that they were really in search of more information about how to use this tool, which pretty much prompted, the creation of this webinar series. So I think we got some good information from that. And also, it also revealed that most of the agencies already have a plan of care and parameters and guidelines in place to identify sepsis. So utilizing this screen tool will really serve to standardize this and focus assessment to, assessing whether or not this patient is indeed meet the criteria for sepsis.
Thank you, Eve. So in our next slide is really focusing on next steps, but before we wrap up with next steps, can we please open the lines again for questions on anything that we've discussed, anything that was discussed by our EHR presenters, or anything that was discussed certainly by Amy in presenting the tool, or really throughout the webinar.
Thank you. Ladies and gentlemen on the phone, if you have a question at any time, please press star and 1. If your question has been answered or you wish to move yourself from the queue, please press the pound key. If you have a question at this time, please press star and 1.
While we're waiting for questions, I just wanted to remind everybody that all of the webinars, recorded webinars, will be posted on the website, the AQUIN website, sepsis webpage, which I believe
It's in the slide.
It's in it was in one of the slides. And you'll get an email notifying you when that's going to be posted. It's usually within a week or so.
And on the subsequent pages of the slides, we're not there yet, but we'll get there. There is our email addresses. So if you have questions that were specific to any of the speakers today individually, or certainly if you want to ask a generic question about the webinar, our resource information is there. Let me focus on some next steps. So in terms of the next steps, the first is that our next webinar, which is geared to focus on train the trainer and will be targeted to agency clinicians, is November 9th from 10:30 a.m. to noon. And we'll let you know if we're going to make a modification to that webinar to also include a deeper dive on today's EHR discussion, or whether or not we will devote that November 9th webinar to the deeper dive and then reschedule the train the trainer. So just stay posted. We will let you know that. Also, in terms of next steps, are the pursuit of opportunities to further support and advance the goals that we discussed in the prior slides, including application for grants, state budget, legislation. Just to review, there is legislation that we've succeeded in getting introduced in the Senate and Assembly that would support quality and innovation projects within home care. One of the prominent ones within that is agency adoption and training and utilization of this sepsis screen. So that is something that both within the context of legislation and in our budget discussions we plan to be raising. The second thing is certainly for us to work towards the whole staff training component and support for that. Work in connection and collaboration with key health and system partners. Just another point on that. I think we're in touch multiple times a week with Tom and the National Alliance on developments and initiatives that we can shape together to support this initiative. The same with colleagues here at IPRO. I do want to give another shout out to the VNAA, the Visiting Nurse Association of America. They have outlined a series of steps that they would like to take, including greater visibility of this initiative. They are looking to work with us to create a spot in their national leadership conference to focus on this. and we're talking about other steps that we can take together. So really wonderfully appreciated the efforts of the VNAA. And as I mentioned, we have the upcoming meetings with the state Medicaid director, with the governor's office, and with other collaborating partners. We'll also continue our collaboration with the Rory Staunton Foundation, as we also work together on the same set of goals for prevention, early detection, and response in the system. One other point I just want to raise with you is the idea of reaching out to media. So September was National Sepsis Awareness Month, and Tom Heymann talked about some of the major attention that's been accomplished in the media, the New York Times, the Philadelphia Inquirer, and other media focusing on this issue area. Part of that's driven by simply the national imperative and the CDC release, but other from the standpoint that some very, very famous people have unfortunately recently died from sepsis, Muhammad Ali, Patty Duke, among them. So it's really, really very, very critical. And in actual fact, when we had representatives from state government on our webinar last time, each of those representatives was a sepsis survivor in their own right and had very critical and really frightening stories to tell about how the system did or didn't really deal early and well with the conditions that they had and whether they themselves recognized those. We also have had some direct success with media attention on this. Amy attracted a feature article in her Utica paper on this whole sepsis initiative in home care, and the article really drills down very, very effectively, explaining exactly what it is and why it's so important. So this is a topic that you may want to consider yourselves as you do outreach into your communities to think about how further public awareness can be spread by what you're doing and also how that might garner further public. We also did a radio show which was featured on multiple stations in the area covering sepsis generally, the IPRO project, and the HCA Tool. So just another thought for you. Next slide. Next slide really points up resources. So we want you to be able to consult with resources if you're looking for further background information on sepsis for your staff or your own planning. And then finally, on the last slide would be questions and comments. I want to invite any of our speakers, if they have any concluding comments to make, either of our electronic health records company representatives, Amy or Eve, any concluding comments?
No.
So with that, I want to thank IPRO, Eve Banker, and Sarah Butterfield for hosting this webinar today, and also for hosting the link to the access to the webinar slides. Tom Heymann and the Sepsis Alliance for your presentation today and for all your partnerships. Amy for your leadership within HCA and in your field with respect to this initiative. Chris O'Donnell and Jonathan Norsinger from Home Care Home Based for your participation and your efforts today and your efforts going forward, and also to thank you for your excellent contributions as members of HCA. And then Jason Banks, Kevin Sherman, and Marie Finnegan from NetSmart, thank you very much for your insights today. We look forward to having both yourselves and Home Care Home Based on a subsequent webinar to delve more deeply. And again, we thank you all for your contributions today.
And I just wanted to add one thing. There were two questions that were emailed in that I will respond to via email and send out the response to everybody.
Thank you very much.
Thank you so much.
I think that concludes our webinar.
Thank you, ladies and gentlemen, for attending today's call. This concludes the program. You may now disconnect.